Hey guys, welcome back. So today we continue the malaria video where earlier in part 1 we discussed the different agents causing malaria and the life cycle, and today we continue with the pathogenesis and clinical manifestations. So let's get started. So basically the pathogenesis or the manifestations of malaria are of two types. We have benign malaria and we have malignant or falciparum malaria. Okay, so we'll talk about benign malaria first. Benign malaria is classically characterized by having febrile paroxysms or episodes of fever, and these episodes of fever, they're actually characteristic because they can be classified in three stages: cold stage, hot stage, and sweating stage. Okay, coming to the cold stage, it lasts for 15 minutes to 1 hour. Okay, and here you get headache, nausea, chills, and rigor. In the hot stage, the fever increases drastically and you have a 39 to 41 degrees Celsius high fever, and you also have burning skin. You feel like your skin is burning. Okay, so we went from chills and all those features to burning skin. And finally comes the sweating stage, where the fever actually comes down because of the profuse sweating, our body's mechanism to cope up. So fever comes down due to sweating, and now you have cold and moist skin. Cold because the fever came down, and moist because of the sweating. Okay, so cold, hot, and sweating stage. Next, we also see anemia, which is of normocytic normochromic type. Normocytic normochromic anemia. There is lysis of RBCs due to merocyte release. Remember, we discussed this in the life cycle video. The merocytes release from the RBCs. Okay, and then they form the gametocytes and also cause the fever. So, a lysis of RBC due to merocytes, then splenic removal of infected and uninfected RBCs. Okay, so the RBCs are also discarded by the spleen, and also bone marrow suppression. RBC decreases here because of the bone marrow suppression. This is what happens this is what the malaria parasite does to the body. Then we also see splenomegaly, which is due to the engulfing of the destroyed RBCs. So the spleen was able to remove these uninfected and infected RBCs, and because of which there occurs splenomegaly. Okay, so these were the characteristic features of benign malaria: febrile paroxysms, anemia, and splenomegaly. Next, we come to falciparum or malignant malaria, which is much dangerous. And the main feature we see here is actually we see that there is an ability to sequester parasites in blood vessels. Attach the parasites in blood vessels of various organs like the brain and kidney. You already must be feeling how dangerous this is, because the parasites are being sequestered in the brain and kidneys, organs like those, which causes naturally blockage of the vessels, congestions, and conditions of hypoxia. Okay, so why are these parasites getting sequestered in these organs and causing these symptoms? Actually, it is because of a specific protein called the Plasmodium falciparum erythrocyte membrane protein 1, PFEMP1. This protein actually binds the infected RBC to the endothelium of the organs, and even the binding of the infected RBCs to uninfected RBCs. So RBCs to RBCs and RBCs to different organs. Because of this, there occurs blockage of vessels, congestion, and hypoxia. Correct? So next, let's go to, so this was malignant malaria, a much more dangerous manifestation. Let's go to the complications, especially of this falciparum malaria or malignant malaria. The complications are cerebral malaria, which is basically the plugging of the brain capillaries as discussed, and this is one of the most serious complications, fatal indeed. And next we have pernicious malaria, which consists of septicemic malaria, algid malaria, and black water fever. You need to remember these are classical questions asked in the exams. You can get each of them for 3-marker questions and even in the viva. So coming to septicemic malaria, here you get multi-organ failure with high-grade fever. In algid malaria, you get shock, hypotension, and cold, clammy skin. Okay, and black water fever, as the name suggests, there will be dark urine, there will be hemoglobinuria, there will be fever, intravascular hemolysis, and so as you can see, all of this is connected, right? The intravascular hemolysis will cause the hemoglobinuria, which appears as dark urine, and there are definitely fever because the RBCs are getting ruptured. And also this can be seen on quinine treatment, because there are actually autoantibodies formed against the quininized RBCs, and this can rupture to actually cause the black water fever. So we have three manifestations of pernicious malaria. We have septicemic malaria, algid malaria, and black water fever as discussed. Okay. Next you have pulmonary edema, hypoglycemia, renal failure again due to congestion by PFEMP1 proteins, remember, DIC, severe jaundice because again RBC rupture will cause jaundice, normocytic normochromic anemia discussed earlier, and acidosis. Okay. So we have this complications, right? The main and the most serious one is cerebral malaria. Coming to the complications, when we don't treat the malaria, it turns into a chronic malaria. First of all, we have a tropic splenomegaly syndrome, the cotton malarial nephropathy, and there is an increased risk of Burkitt's lymphoma. So firstly, looking at tropical splenomegaly syndrome, here it is because of the abnormal response or the exaggerated response of the body to the malarial parasite. Okay, next, the cotton malarial nephropathy. Here there is immune complex deposition in the renal glomeruli, okay, in the kidneys, right? And since it's nephropathy. Next, there is an increased risk of Burkitt's lymphoma. And why? This is because the malarial parasite actually causes an immunosuppression which increases the cancer risk. Okay, so these are the chronic complications. Next, let's get to the lab diagnosis. And here, first of all, we discuss the specimen taken. Specimen are the fingertips and earlobes. We take the blood from these places, a classical viva question. The peripheral smear is should be collected. You should note this, that it should be collected a few hours after the height of the fever and before taking the anti-malarial drugs. Okay, after fever and before taking the drug. Now, the smear we take should be 2 thick and 2 thin smears, right? 2 thick and 2 thin smears. And the stains used are classical Leishman stain, Jamesa, Fields, Wrights, and Jaswant Singh and Bhattacharya stain. Okay, so coming to the next, the fluorescent microscopy or the Kawamoto technique, right? Here the blood smear is added to the acrid and orange dye, and what we see is that the nuclear DNA is actually stained fluorescent green, while the parasitized RBC, it appears as brilliant green dots. The RBCs or the merozoites appear as brilliant green dots. Okay, and the nuclear DNA is fluorescent green. Next, coming to the antigen detection. Okay, first, so yeah, this is the fluorescent microscopy. Next, coming to the antigen detection. This is also important because what we detect are the antigens of the parasite lactate dehydrogenase, PLDH, parasite aldolase, and histidine rich protein 2. Okay, these are very important. Next, a very important test now we'll discuss, where actually 2 parasite detection lines are made, test line 1 and test line 2. What this means is that in the test line 1, it is actually coated with antibodies specific to Plasmodium falciparum, capture antibodies. In test line 2, capture antibodies common to all the rest of the Plasmodium are coated. Okay, so basically in first line coated specific to falciparum, second to all other Plasmodium. Next, the blood specimen is dropped on these test lines and color band forms, indicating this is a phenotypic test. The color bands are formed. If it is formed in the test line 1, it indicates a falciparum infection. Test line 2, other than falciparum infections. And if the color band is formed on both test lines, that means it was a mixed infection. Right. So this is a very important test because it can come as 3-marker questions and also in your viva. So it is very important. Next, coming to the molecular methods, we have nested multiplex PCR, the normal PCR, and the real-time PCR. Okay, classical. So this was the lab diagnosis basically, and also we discussed malaria completely. Now, first video we discussed the agent and life cycle, and now we covered the pathogenesis, benign malaria, falciparum malaria. In benign we have febrile fever and splenomegaly. In malignant, we reason why there is blockage of vessels, congestion and hypoxia in organs like the brain and kidney, right? Complications we discussed, most serious cerebral malaria. And in pernicious malaria, remember the 3: septicemic, algid and black water fever. You don't want to forget these. And we have other renal manifestations, jaundice, anemia, right? And if not treated, converts into a chronic form. The chronic complications being tropical splenomegaly, cotton malarial nephropathy, and Burkitt's lymphoma, right? And definitely the lab diagnosis, which is very important. Things to note here are the specimens, right? And the fingertips and earlobes, you have to take the specimen from that place, and also when to take the collection, after the fever, before antimicrobial drugs. Blood smear accurate in orange, fluorescent green, brilliant green dots of RBCs, parasitized RBCs, right? Also the important antigen detection tests, classical, the test line 1 and test line 2, you need to know this, right? The different bands which are formed, color bands. So this is the basically the malaria video, and this is the complete video. I hope you guys liked it. We've covered it in part 1 and part 2. Thank you.